Good afternoon, everyone, and thank you for joining RadSite for our summer session webinar series, today entitled The Right Choice, RadSite's Accreditation Roadmap. My name is Mark Casner. I'm the chair of RadSite's Accreditation Committee, and I will serve as the moderator for today's webinar. Before we begin, I'd like to go over a few housekeeping items. Today's presentation will be recorded, and an email will be sent this week to all individuals who registered containing a link to the recording. Second, to minimize noise and distraction, all attendees' phones are muted. However, if you have a question or comment during the presentation, we encourage you to submit it using the question and/or chat box section on the lower right side of the webinar portal. Let me introduce today's speakers. First is Dr. Phillip Patton. Dr. Patton received a Bachelor of Science degree in Physics from Augusta College in 1990 and a Master's of Science in Nuclear Physics from the University of Georgia in 1993. He proceeded to the University of Florida, where he earned a second master's degree, this time in health physics, medical physics option, and a PhD in medical health physics. He's a certified health physicist, a diplomat of the American Board of Radiology, and a licensed medical physicist in the states of Arizona, Nevada, Utah, and Florida. We have Jonathan Ramirez with us today. Jonathan is the Director of Sales and Marketing. Jonathan was involved with the development of Avamid at Avid Pharmaceuticals, which is a PET tracer. He is a certified or a registered technologist, and certified in both radiography and computed tomography. We have Dr. Bruce Reiner, who's our Chief Medical Officer. Dr. Reiner is a radiologist. He has published more than 100 peer-reviewed articles. In addition, he has a number of patents to his name. And finally, we have Dr. Eliot Siegel, world-renowned radiologist. Pardon me. He's a professor and chair and vice chair at the University of Maryland School of Medicine, Department of Diagnostic Radiology, as well as chief of radiology and nuclear medicine for the Veterans Affairs Maryland Healthcare, both in Baltimore. And finally, we have Julie Irons, who is our accreditation manager, and Judy Behm, who is our RadSite accreditation reviewer. Our agenda for this afternoon will include preparing to apply for certification, tips to ace the application, image quality assessment, physics assessment, how to prepare for an on-site audit, and looking to the future. And without further ado, let me turn it over to Julie Irons.
Thank you, Mark. The first step in the application process is to obtain and review the RadSite standards. There are only 7 of them. The standards are designed to show RadSite who you are, what you do, and how you do it. In the first standard, the imaging provider information, we are trying to obtain the necessary information to evaluate the merits of your facility and its imaging system or systems. In the second standard imaging system, we are ensuring that your imaging system is installed, operated, and maintained according to the requirements of the manufacturer, as well as federal, state, and local government agencies. With the next 2 standards, professional qualifications and professional oversight, we are working with you to ensure that you have in place the applicable personnel policies and processes to employ the best staff for all key positions. Under the policy and procedure standard, we want to be sure that you, the facility, is striving to develop, approve, maintain, and review and/or advise your policies to always stay best in practice. The quality and patient safety standard is looking to see that the facility has structured approach to reviewing its processes so its business and clinical decisions can promote operational integrity, clinical efficiency, and patient safety. The last standard, technical quality, deals with scoring of the images and the physics review. It outlines the requirements for each imaging system. If you don't have a copy of our standards, you should visit our website, www.radsitequality.com, and after completing a short form with some basic information, you will be able to instantly download the standards. Okay, preparing to apply the application components. There are 3 parts of the application: the questions about your facility, personnel, and imaging system, the section about document submission and required documents, and then the last section on uploads of your images and your phantoms. Our application is completely online, and there are no CDs to be mailed in. Although we have worked with small doctors' offices who cannot upload their images online, and we do accept CDs for those applicants. In the first section, the application questions, we will ask questions concerning standards 1 through 6. The questions follow the standards, and reading them in advance, you should have no trouble in responding to the questions. The second section, the document submissions, I again advise you to highlight the information in the standards to help you prepare for what is required. RadSite, we also can provide you with a document checklist so that you have all the required documents in one place. This section may take you the longest to pull together, and you may need help from your HR department. The last section of the application is the uploading of the clinical images and corresponding reports and the phantom images and physics report. This is done through AMBRA DICOM grid. The portal provides you with a link to the image share step-by-step upload. Drs. Reiner and Patton will provide you additional information about what is expected in their presentations. Our application portal allows you to work at your pace. You can start and stop as needed, and you won't lose any of the responses that you have uploaded. Lastly, preparing to apply. As I discussed earlier, having the standards is the first step, and you can download those from our website. Once you have reviewed the standards and are moving forward, the next step is to register in the portal and start the registration process. What I would suggest is that before you start, you contact RadSite either through the sales department or the main office and ask to be sent the 2 agreements, the MAP agreement and the HIPAA BA agreement. This will allow you to review those documents before you actually start and have them prepared and signed and ready to upload into the portal, as that's one of the first steps that you will have when you start the registration process. We can also provide you with the tutorial of the portal and the checklist for the required documentation. The tutorial provides you with a step-by-step of the application process. We've taken screenshots of the actual process to make it as easy as possible for you, the applicant. The document checklist puts all of the required documents and descriptions from the standards in one place for ease of assembling them. We also preface each section with examples of the documents we are looking for. As your account manager, I will be the point person throughout the application and review process, so feel free to contact me directly with any questions you have. We strive to make this process easy for you, even though you'll find our standards to be rigorous and best in class. Now, let me hand the presentation over to Judy Behm, Administrative Reviewer, and she will provide you with some tips on what a reviewer is looking for on the admin portion of the review.
Thank you, Julie. As a RadSite Accreditation Reviewer, I understand that this process can seem rather daunting, but I'd like to provide a few helpful tips that might make the job a little less stressful. First, there are 2 documents that I would suggest you have open and easily accessible. The document checklist, which Julie just referred to in her presentation, provides all the required documentation you'll need in this application. And it includes examples that we would accept But remember, these are just to point you in the right direction. There are many, many documents that you probably have easily accessible that don't actually fit the example we provide. If you have any questions, this is a time you can contact your account manager. Second, you want the standards available for quick reference. First, I suggest you read through the standards at least once prior to starting the application. In each of the standards, there's a section entitled Further Explanation. And in that, you're going to find a brief paragraph or two that will explain the intent of the standards, and that may help clarify what we are actually looking for. Also, as you fill out the question in the application or you gather your documents, have the standards available so that you can reference them, and most of your questions will probably be answered. We do ask for a lot of policies as part of the documentations, but we are looking mainly to see that the policy contains those items spelled out in the standards. But also we want to know that these are your policies. So at a minimum, the header should contain your company's name. We really want to avoid someone going in and copying and pasting off something from the internet. This policy should be yours. Also, policies to be reviewed annually. Each policy should have a place for a reviewed by date and a signature for the reviewer. And these should be filled in. I know that sounds a little odd to say why that would be left blank, but we do receive policies that have a place for a date and a reviewer's signature, but they fail to fill in that information. And at that point, we would have to reject that document and ask them to send us a new one. Also, we understand that there are binders or files that contain all of your policies, and you may have a table of contents that has the review by date and a signature. And in that instance, we do accept that document as well as the policy to verify that you are going through all of the policies and reviewing them. Read the questions carefully and double check your entries. We're looking for dates that have expirations for licenses. If you miswrite and put in a 7 instead of an 8, which isn't hard to do, it may mean that that's a red flag and we couldn't accept it because the license has been expired. So please double check that. Also, your NPI numbers. There's a lot of numbers to put down there. It's not hard to forget a 0 or to put in 2 9s. But remember, if you enter an NPI number, you may delay reimbursement from CMS. We also have the next thing, which is maybe requiring your HR department to help you through this, because we are looking for qualification documents for your professional staff that verify their credentialing. And this can be such things as the ABR license or an ARRT registration card. Again, we understand that sometimes it's hard to keep some of your files up to date with the most recent version of the card. Maybe your staff member has just received their new card and you don't have it in the system. But please check and make sure that you're not sending us an expired image of one of these licenses, because again, it would be rejected. And finally, if at any time you are confused, you need more clarification, contact the RadSite account manager. RadSite is here to assist, and that's what we pride ourselves on, of being available and helping you through this process. Next, Dr. Bruce Reiner will discuss the image quality assessment.
Thanks, Judy. I wanted to start off by talking a little bit about the current state of the accreditation process. And I think one of the things that I think is surprising to me is the extreme amount of variability in image quality in everyday radiology practice. And one of the things that basically struck me was several years ago, we did a research project where we compared image quality between technologists in several different radiology departments. And we found an unexpectedly high variability between technologists. And ironically, the technologists that were the most productive in terms of the number of exams and patient throughput, ironically had the worst image quality. And in the current practice environment, oftentimes department administrators will praise the technologists that are the most efficient And ironically, those technologists, in many cases, are actually producing the poorest image quality. So one of the things that we at RadSite would like to do is create an environment where image quality is much more consistent and of higher quality throughout the process. One of the challenges for us as an image quality accreditation process company is that we have to come up with a consistent and uniform process in terms of analyzing image quality. And unfortunately, the current practice basically takes image quality and looks at it more for the aesthetics. It's more of a beauty contest type of process. And part of the problem with this is the fact that in conventional practice, we ask for the individual applicants to choose the individual images that they want to submit. And oftentimes, they choose the best quality patients with the least amount of pathology. So if we ask them to submit 3 or 4 MRI studies, they'll usually take the 18-year-old male who comes in with headaches and not the 65-year-old woman who basically has had previous surgery. So we need to basically create an environment where we look at all different types of patients with all different types of pathology and move away from this beauty contest type of phenomenon. In the absence of a standardized and objective process, right now, RadSite, as well as all the other accreditation organizations, are really basically providing a disincentive to our customers because we're not really analyzing image quality in terms of the real life situation which we practice. And what we have to do is strive for a more consistent and objective process that adds value to the customers. So on the next slide, I basically listed a number of what I call image quality metrics. And these are things that basically we use in everyday practice. And there are a list of individual metrics that one could basically utilize when grading image quality. One of the things that I think what we need to do is instead of going away from the binary approach where we say, is this or is this not an image of sufficient quality, we should really look at the individual image quality metrics that I listed and look at them on an individual as well as collective basis. And if we apply a numerical score of 1 to 5, we can literally come up with a more analytical approach where we objectify image quality analysis. If I go back to the study that we did several years ago and showed tremendous variability in terms of image quality amongst technologists, interestingly enough, anatomic positioning was the highest frequency of image quality deficiency. And oftentimes what would happen in the study that we did, which looked at general radiography, is a technologist would cut off a portion of the anatomy, let's say the apices on the chest radiograph. Now, most of the time that wouldn't necessarily have an adverse effect on diagnostic accuracy, but the important thing is you want to make sure, obviously, that the complete field of view is present in order to capture any type of pathology. And in a couple seconds, I'm going to talk about the other thing that often goes unnoticed, and that is radiation dose. And when we are looking at, for instance, a cervical spine CT in our image accreditation process, one of the things you have to look at is too much anatomy included on the study? So what we find frequently is sites that basically do cervical spine CT will actually go into the superior thorax. And in doing so, they might go all the way down to T4 or T5. Now, while they're certainly covering the full anatomic region, they're actually covering too much, and that causes increased radiation dose to the patient. So one of the things we want to do is we want to balance out the competing demands between how can we achieve the maximum image quality, but at the same time, the lowest radiation dose. So we, as an accreditation organization, have an opportunity that we can basically not only provide image quality analysis, but also education to our customers. And one of the ways we can do that is to create uniform standards and educational resources in image quality analysis. So in the previous slide, I listed a number of image quality metrics. And what we would like to see is to not only objectify and include these into our image quality analysis, but also create a uniform scoring system so that we can provide objective grades for the individual images on the basis of these individual image quality metrics and actually provide them back to you, the customer, for educational feedback. And if we took those images that we captured and we used in the scoring process and actually incorporate those into a library or a database, we could actually create a searchable, referenceable database for educational purposes. So for instance, if you submitted a chest CT and we said that you had significant motion artifact on there with a low grade, you could literally search that database for educational purposes and be able to see the difference between what constitutes a motion artifact score of 2 versus a motion artifact score of 4. And the whole purpose is not only to objectify and standardize the process, but also create educational resources. Now, there's a number of additional innovation opportunities which obviously go well and beyond our role as an image accreditation organization, but we would like to see basically these incorporated into the radiology community. The first thing I mentioned is we need to get away from the idea of submitting the aesthetically pleasing images and actually create a real-life environment where we submit images from all different types of patients with all different types of disease processes in order to reflect the real-life world in which we live. The other thing I think we have a tremendous opportunity is the concept of ALARA, which is as low as reasonably achievable. And the whole concept, as many of you know, is when we take ionizing radiation examinations like a CT scan, we want to create a balance. On one hand, we want to have image quality that is sufficient to render accurate diagnosis, but we also want to utilize the lowest possible radiation dose for patient safety. And one way we can do that is to actually create an index where we actually create quantitative metrics where we balance out image quality and radiation dose simultaneously. The other thing I think that would be really valuable is if we move away from the subjective human-based analysis of image quality and eventually work towards developing computerized algorithms so that we can use the database that we create from the referenceable library and actually teach computers to create algorithms to measure image quality. And if that literally could be incorporated into the modality to get instantaneous feedback at the point of care. The other important thing that we like to do is we like to think of ourselves as educators. So one of the things we'd like to do is take some of the information and the knowledge gained through the image quality process and share that with our customers for educational content, as well as customized image quality analytics. So for instance, if we had one particular CT scan or one particular technologist or one particular exam type at an individual site that basically was relatively deficient relative to the peers, we would like to be able to give you not only the feedback of where the deficiency is, but how we can improve that. And the last thing I wanted to mention is the fact that image quality analysis currently looks at one single step in the imaging chain, and that is image acquisition. But there's a 16-step series of events from the time the examination is ordered to the time the report is completed and shared with the referring physician. And all those individual steps ultimately create an opportunity for quality improvement. So in my last slide, I just wanted to share with you pictorially the difference in image quality between a conventional radiation dose CT, which is labeled as A on the far left, and then 50% reduction radiation dose in B. And you can see how the images are very grainy with a lot of noise. And if we do want to basically decrease the amount of radiation dose consistent with the principles of ALARA, we have to balance out the competing demands with image quality and radiation dose reduction. And the best way to do that is through the analytical approach that I talked about. So I just wanted to kind of share with you our approach and our vision in terms of where we want to go and recognize the fact that there's a lot of opportunity for education in amongst radiology providers. Thank you very much.
So I'm actually going to talk about the physics component of the accreditation and the assessment we do. So the first major component is the medical physics report. Each modality should be tested annually and have a medical physics report that's generated. The physicist should be a licensed medical physicist and should be familiar with what type of tests are appropriate for the particular modality. And when they generate this physics report, they're going to use obviously some approved phantoms that we can measure image quality, and we can actually assess dose if it's applicable for that modality. At RadSite, we take a different approach than some accrediting bodies. We actually do not define the phantom you're going to use. We allow more than one particular phantom. Of course, you have to submit the manual for that phantom if it's not one of the ones we've already approved, so that we know that it meets our standard. So CT, we've actually looked at 3 phantoms that we've already approved: the CAT fan, the GAMX 464, and the AAPM CT performance phantom. MRI, we've approved 2 MR phantoms. And for PET inspect, we've looked at 2 phantoms as well that's already been approved. So if you're going to use any of these 7 phantoms, there's no reason to submit the manual for it. However, if you have a vendor-specific phantom that you think will meet the requirements, the medical physicist should probably submit the manual, and we can discuss if it's appropriate. This is one measure that we can save the applicants some money, where they don't have to go out and buy a specialized phantom. And so we think it's kind of conducive for the facilities. So what do we evaluate when we look at these different modalities? For CT, we look at things that have an impact on dose and image quality. As mentioned previously, those are our concerns. We want to make sure we're balancing between dose and is the image acceptable for the radiologist. So we look at the CT number accuracy. We make sure that the slice thickness is appropriate and that it matches up to what is being prescribed. We look at the CT number uniformity, how uniform is the image. We make sure that we can detect the objects we should. So we looked at a high contrast resolution, and more as we go along with that and we reduce the dose, we know that we start to lose some of our low contrast detectability. So we evaluate the low contrast detectability. And then finally, we look at the dose to make sure that we're not overdosing the patient. For MRI, it's similar in the fact that we look at slice thickness accuracy, we look at high contrast spatial resolution, low contrast detectability. But since it's a different modality, we look at the homogeneity of the magnet. We also look at the geometric accuracy because MRI doesn't have the same geometric accuracy as CT. We also look at how uniform the images are, but we use what we call the image intensity uniformity. And finally, since MRI has something that we call ghosting, which it basically is a distortion through one of the planes, we look at the signal ghosting percentage to make sure it's acceptable. The other modalities we look at is nuclear medicine and PET. So nuclear medicine being either planar nuclear medicine or SPEC. And so when we look at that, we look at uniformity both intrinsic and system-wide. We look at the spatial resolution for intrinsic and system-wide. And we make sure that the unit can actually measure the counts it has, and that's a way for us to measure what type of dose the patient's receiving. If the sensitivity of the unit is not up to par, we're going to have to overdose the patient to get a good quality image. And if they're submitting for SPEC, we again look at contrast, uniformity, and resolution, just like if we did for planar. So if you're submitting for SPEC, you also have to submit planar images, so it's kind of a double evaluation. Our PET evaluation, we look for SUV accuracy, and we evaluate the SUV to make sure there's an appropriate uptake. We again look at spatial resolution to make sure we can see the objects we should. Is the objects uniform? And then finally, what type of contrast do we get?
Great, thank you, Dr. Patton. I'll be discussing the on-site audit process. This process consists of the following: a walk through the facility, checking our internal audit checklist, auditing personnel CE credits, licenses, and checking areas where improvements need to be made for identification of MRI safety and CT radiation safety. Next slide, please. The walkthrough will assess the reception office, how patients are greeted, exam instructions on whether the patients need to change out of certain articles of clothing into a patient gown, proper signage of the facility for patients to easily distinguish restricted areas, MRI safety, radiation safety, and emergency exits throughout the facility. For patients undergoing nuclear medicine scans, the patients should be sent to another room where patients can sit during uptake of radioisotopes away from patients who are not undergoing nuclear medicine scans. Next slide, please. And the audit checklist will review the following: the compliance program that monitors the federal and state regulatory requirements, the credentialing policies for the personnel, the policies for imaging equipment, and the OSHA policies. Next slide. All personnel who operate a CT, MR, PET, or SPECT imaging equipment are required to have continuing education credits, licenses in good standing by either the ARRT, ARMRIT, or the NMTCB. All interpreting physicians should have continuing medical education credits available upon request and should be licensed by the American Board of Radiology, American Osteopathic Board of Radiology, or the American Chiropractic Board of Radiology. The next slide, please. For MR safe and non-MR safe items should be labeled for proper identification of what can and what cannot go into the MRI room. A patient should be instructed to prepare for their exam and should be screened prior to entering their exam. That does include BUN and creatinine labs for injection of gadolinium, as well as any contraindications, reviewing the patient's history. Next slide. And for CT radiation safety, also changing instructions for patients when preparing for CT. Again, BUN creatinine for injection of iodinated contrast, screening for any type of allergies or contraindications, and post-injection instructions on patients that are have diabetes or any other contraindications. And with that, I'd like to turn it over to Dr. Eliot Siegel.
Thanks, John. And I think that in the future, there are lots of opportunities for us to have significant improvement and for the accreditation process to continue to evolve as technology changes and as we end up discovering new ways and new innovative solutions to being able to look at how does one accredit in such a way that one can ensure the highest possible safety and quality of care for our patients. And ensuring safety and quality of care can really be a challenge. I mean, we've seen a wide variety of different equipment that's being utilized throughout the United States with regard to age, maintenance, software version, et cetera. And this can lead to a major variation in image quality, even for relatively new equipment and even within a single institution. So one question is, how can we create something in clinical practice that would be much more rigorous and maybe something closer to what we do with clinical trials? And so one of the initiatives that I'm really interested in is working in concert with KIBA, which is the Quantitative Imaging Biomarkers Alliance. It was an effort started with the RSNA and led by Dr. Daniel Sullivan, who was at the National Institutes of Health before coming to work with KIBA and the RSNA. And that KIBA effort has been looking at mechanisms to be able to create uniform quantitative analysis and uniform images in CT, MRI, nuclear medicine, particularly PET CT. And I'm particularly excited about the potential for our accreditation organizations, such as RadSite, to play a major role in the adoption of profiles and protocols to help ensure uniformity across different institutions and different machines. And I believe that there's the potential for us to be able to help KIBA finally reach some of its objectives. It's done a great job with regard to the research. It's got great background, very specific recommendations, and even phantom ideas and recommendations. What would be fantastic would be to combine the KIBA effort in our accreditation process. And so organizations would be rewarded for being able to ensure quantitative uniformity with a standard. And I think it would also accelerate adoption of KIBA also. So the second thing that I'd like to talk about with regard to looking to the future is creation of a culture that enables continuous quality assessment using innovative hardware and innovative software that can enable sites to maintain a high level of performance and quality. Essentially, as Dr. Reiner pointed out, the process that we have right now of looking at a small subset of images on a interval basis is probably not as good as having a culture of continuous quality assessment by the imaging sites themselves. And so creating a mechanism where one would not have to scramble every once in a while to get these images and to go through the process, but where there would be mechanisms that would be built in to one's own quality assessment process at one's own facility. So when it came time for accreditation, one could just upload the data that had already been collected during the accreditation interval. And so I think this would make accreditation a relatively automated process using data that the site's already acquired with the potential for a direct interface with the electronic medical record or radiology information or PACS software to collect these data continuously. And so one would be able to have the ability to be able to document a continuous level and high level of safety and quality. And so I think this could also be utilized to benchmark across multiple accreditation sites. And it would be great to be able to provide feedback to our various sites about how they're using, how they're performing with regard to radiation dose and equipment maintenance and a variety of other parameters. And I think that that would really add tremendously from an education perspective and also allow us to really have very meaningful application and very meaningful utilization of accreditation organizations. So looking to the future, we would love to hear your own thoughts and suggestions about future directions for the accreditation process as a continuous program. What areas might be useful to concentrate upon, and what are your thoughts just in general about where you think the accreditation process should go? What's been positive about it for you, and what are things that you'd like to see improve? I know when I speak with my colleagues in radiology, lots of them have ideas for how they might improve the process and how they might make it more relevant and how it might be able to directly or more directly translate into patient care improvements. So, you know, I think that there are opportunities for within the accreditation organizations and process of sharing best practices and experience with specific machines and maintenance on those. And it would be great for the accreditation organizations to maintain and share some of that database with some of the institutions that we accredit. So any additional ideas would really be very much appreciated. So thanks very much for the opportunity to sort of peer into the future a little bit, and love to get some feedback about some of those ideas. So thank you.
Okay, so that concludes our formal presentation. We've got some time for questions and answers for those out there. Again, a reminder, if you can, just type in the chat box down in the lower right-hand corner there, and then we can read the questions back to the panelists. We do have a few questions to ask right out of the gate here, and Julie, perhaps we start with you. What happens if I don't pass the review?
RadSite has a very educational approach to the review. We do what we call the first pass through, so to speak, where each reviewer goes through their part, because there are 3 reviewers who do the review. We've got Judy or another admin reviewer. We've got then the radiologist who reviews your images and corresponding patient reports, and then a physicist who reviews the physics piece. If anything is missing, we will get back to you with notes from the reviewer letting you know what is wrong. We will reopen your application, give you that opportunity to go in and review and make any necessary changes or edits that need to be done. The reviewers will then, once you've resubmitted, the reviewers will review that material that you resubmit and go through it. There is no additional cost for resubmission of any part of the application. And most people that go through and resubmit, and they're usually pretty good. If there is an issue, a second issue or a continuation of the issue, typically we try and hook you up with the reviewer to make sure you're understanding what's going on. At that point in time, if there's still issues, then the application may need to be resubmitted at another point. But for the most part, it's usually good once they've understood what the RFI, that request for additional information, what's been issued or done wrong, and they're able to fix it and get through accreditation with us.
And just to add a little bit to that, overall, as Julie said, RadSite's emphasis is on trying to raise the bar, raise the quality for imaging in general at the sites that we do accreditation. And the focus really is on trying to educate the sites as much as possible. So even though the standards have a relatively high bar, and we're really rigorous about that, I know from experience that a lot of folks end up failing the accreditation process with other accreditation organizations due to technical issues related to they did submit this the right way, or this wasn't done properly, or they had a misunderstanding in the submission process. And so in general, RadSite's philosophy is to try to help educate, try to help correct some of those issues. And if there's a machine that really merits passing, given the high standards, then we make every effort to try and work with particular facilities to have those sites pass if their equipment really is up to speed, rather than having a technical or submission error create a failure. So thanks for the question.
Thanks, Julie, and thank you, Dr. Siegel. Let's switch gears here and go to the end of the process, which are those on-site audits that happen afterwards. So a question for John, does the facility get notified before an on-site audit? And if so, what is the process? And how long does the on-site audit take?
Thank you, Mark. So this is a fairly easy question. The audit process typically takes between 2 to 3 hours per facility. And we do give a courtesy notification either 2 weeks beforehand or as far as a month beforehand.
Okay. And let's move back to Drs. Siegel and Reiner, and I'm not sure Dr. Patton is still on the line, but one of the questions or concerns we get from time to time relates to age of equipment, whether the hardware has been updated, the software has been updated, is the field strength an issue? If one or more of you could address some of those issues and what the sites can do to assure us that the image quality, et cetera, is up to the current standards.
Right. Well, let me start, and maybe Phil can elaborate a little bit if he's still on. But overall, it's a really important question, and our idea within the RadSite Standards Committee is constantly changing and evolving as far as that goes. But overall, our process has up until now been that if the equipment is able to pass our physics standards and requirements, which are fairly rigorous and do exceed that of some of the other accreditation organizations, but if equipment is able to do that, then in general, we've passed that equipment. And so we'll often make a comment saying that, it kind of barely passed, or, at this particular field strength, then the images were okay, but, this would have been done better at a higher field strength, perhaps. And so we'll try and provide some additional information and feedback. But given the physics standards that we have and requirements, as long as one is able to pass those, we don't have any arbitrary standards at this point as far as software version or as far as age of equipment, et cetera. There's been a fair amount of discussion at the standards committee level about whether or not there should be age standards or whether there should be field strength cutoffs. And I think as time goes on, it's likely that we'll start looking at some of those and implementing some of those. But at this point, it's mainly if you meet the specifications that we have that are objective, that are set up, then you have the ability to pass. So it's a great question, and lots of people are giving us feedback suggesting that we be a little bit more rigorous about things as far as age or as far as field strength or as far as, for example, how many slices a particular CT scanner should have if they're going to be doing a CT pulmonary angiography or other things that require fast scanning. And we're looking into all of those at this point. So great question. Phil, if you're on, any additional comments?
Dr. Patton's not, but I'm on. This is Joe Howley. I'm one of the other physicists for RadSite.
Oh, great. Okay.
I
thanks,
definitely
Joe.
agree with everything you said, Eliot. And to your point, a lot of times the lower field strength magnets can't pass a lot of the physics requirements, especially if they have any issue at all going on. If they're not perfectly tuned and everything's not working properly, they will not pass some of those small, the lower end open magnets with the small fields. And to your point, definitely agree. Some of the newer imaging with CT, where you're doing a lot of stuff and it's really fast, it gets really hard to do and have it done properly if you don't have, probably at least like a 64 slice scanner to be able to do a lot of those studies. And that is something that definitely at some point probably will have to be taken into account for some of the more specialized studies within the specialized imaging of CT and MR.
Thanks. And we've been responsive to some requests that we've gotten for a higher level of standard, for example, for cardiac imaging, to have a particular accreditation or a particular set of special excellence for cardiac imaging, for example. And so for cardiac imaging, we would look at issues such as single versus double injector. We'd look at issues such as number of slices and look at a number of other parameters that would be more specific to higher end, faster images, such as, for example, CT rotation time. And so I think we'll be looking at evolving and creating these areas of excellence that would look more particularly at the types of studies that are being done. So thanks for the additional physics comments too. Really appreciate it.
Okay, and for those of you just joining in, that was Joe Howley, who is Dr. Patton's partner. So Joe, thank you for joining us. And Dr. Siegel, thank you for answering that question as well. We have time for a couple more. If anybody has any last minute questions, we'll entertain that now. Okay, looks like we've exhausted everybody this afternoon. Thank you again for attending today's webinar. We hope that this discussion provided valuable insight into RadSite's accreditation program. In case you missed the last webinar, Macro Simplified, or any of our past webinars, we invite you to visit our website, www.radsitequality.com/webinars to learn more. If you have any questions following this presentation, please email them to info@radsitequality.com and the appropriate panelist will respond. Again, thank you for attending today's seminar and have a great rest of the day.